Hi, good afternoon, and thank you for joining us on another edition of To Your Health here on GBMC Facebook Live. I am your host, John Lazaru. Did you know that next to skin cancer, breast cancer is the most common cancer diagnosed in women in the United States? But did you also know that breast cancer can affect both women and men? Joining us today to get a better understanding of the various treatment options for breast cancer, which includes immunotherapy, as well as chemotherapy and other targeted treatments, and the role of a medical oncologist in the treatment of breast cancer, is our very own Dr. Robert Donegan, a medical oncologist with GBMC's Sandra and Malcolm Berman Cancer Institute. Dr. Donegan, thank you for coming again here to Your Health. It's always a pleasure to have you.
Thanks, John. It's great to be here.
All right, so let's get going because we got a lot to talk about, as we discussed before the show went on air. Let's talk about your role first as a medical oncologist. Can you possibly explain your role and your training and when it comes to breast cancer treatment for our audience here in the studio and those at home?
Sure. So a medical oncologist is one member of a much larger team. Before talking about the medical oncologist, make note that there are surgical oncologists or breast oncologists, radiation oncologists, integrative medicine therapists, psychologists, social workers, infusion nurses, dietitians, geneticists. It's a real team approach to how we best care for our patients. And so I'm just one part of a much larger team. So the medical oncologist plays a variety of different roles. I'm not a surgeon. I'm not a radiation oncologist. I don't do any of that. What I bring to the table in the care of our patients are many of the medications that can be effective at preventing breast cancer from recurring or treating breast cancer when it's in its more advanced stages. And oftentimes we also, as medical oncologists, play a bit of a quarterback role once the baton has been passed from the surgeon, who is often the first person that the patient encounters. And then we help coordinate much of the care through therapy and into survivorship.
So let's talk about breast cancer.
Sure.
Let's start with, what are some of the early signs of breast cancer?
So it's different for every story. Oftentimes there are no early signs. When breast cancer begins, it's oftentimes very small and can't be detected. Indeed, that's the whole rationale for screening mammography, is to try to find breast cancer before anybody else can feel it. That said, some patients do notice the cancer themselves, or it may be found at the time of a clinical exam with one of their physicians. And so there are several things that we look for. We look to see if there's a new lump or a new mass within the breast itself, or even within the armpit, which could be a lymph node that's related to the breast cancer. We look at changes within the skin. So there can be thickening of the skin, there can be redness of the skin, there can be flaking of the skin. Anything that seems out of the ordinary is certainly going to catch our attention. We look at whether there's a change in the size of the breast that's new. We look at the nipple to see if there's a mass within the nipple, or maybe some nipple discharge, particularly if there's blood from the nipple, particularly if it's on one side rather than both sides. We look to see if there's an inversion of the nipple, that is a dimpling of the nipple that was not there before. So there's a whole variety of different physical exam findings that could be how a breast cancer presents. A lot of times people ask about pain. Fortunately, pain is usually not caused by breast cancer, but rarely it can be. So I think if there's pain without any other explained reason, it's better to have it checked out.
So you talked about the breast cancer, but let's talk about the many causes and possibly the different types. During my research, I found that there are different types of breast cancer. Can you elaborate on that?
So let's cover the causes first. So first of all, most women don't have an identifiable cause for breast cancer. And that's important to understand. A lot of times people think, well, I don't have a family history, so I don't have to worry about it. Well, most don't have a family history when they're diagnosed with breast cancer. About 5 to 10% of breast cancer is actually caused by an inherited gene that one can get either from the mother's side or equally from the father's side. So that's a risk factor, but only for a small proportion. We know that obesity is a risk factor, and that's something that's more common in our society, so it's something we have to be mindful of. We know that hormone replacement therapy taken after menopause, especially if it's combined hormone therapy, estrogen and a progesterone, it can be a slight risk factor for breast cancer. Birth control pills, uncertain. Some people think that some studies show a small risk, many others show that there's not a risk. So again, risk factors are only present in a small proportion of patients. Most patients, it just happens with age and obviously being a woman. And I think the reason that's so important is that don't think that you're safe just because you don't have a risk factor. That's why screening is so important. The other question you asked is what are the different types of breast cancer? And there's a lot of ways to think about this. Most breast cancer arises from the duct within the breast, so that's called a ductal breast cancer. There are also lobules within the breast, which are where milk is produced, and so a minority of cancers, 20%, arise from the lobules. So that's one way to divide up breast cancer. Another way to think about it is invasive breast cancer, which is breast cancer that has invaded in the breast and can go to other places, versus non-invasive breast cancer, something you may have heard of called ductal carcinoma in situ, or DCIS. That's breast cancer that's very early that hasn't yet learned how to travel to other places. Another way to subdivide it, John, is to look at it in the form of staging. So we have 5 stages of breast cancer, stage 0 through stage 4. Stage 0 is the non-invasive breast cancer that I just talked about, and stage 1, 2, 3, and 4 progressively become more advanced. Stage 4 breast cancer is breast cancer that's traveled to other parts of the body. Stage 1 is very early breast cancer, and 2 and 3 is either a large tumor and or a tumor that has spread to the lymph nodes within the armpit. So a lot of different ways of describing the different types of breast cancer.
Again, joining us today is Dr. Robert Donegan, a medical oncologist and hematologist with the GBMC Sandra and Malcolm Berman Cancer Institute. Before we get to our questions from our audience members and those watching us at home, and for those watching us on Facebook, if you have a question, please feel free to enter it in the comment section, or for privacy purposes, feel free to private message your question to us, and we'll do our best to get it answered by Dr. Donegan. Dr. Donegan, before I get to those questions, one last one. How is breast cancer prevented, if possible?
So, great question. Well, I already mentioned that certain lifestyle choices may increase the risk for breast cancer. So, physical activity, a healthy diet. We talk about a variety of different diets, but the one that we tend to think most about is a plant-based Mediterranean-like diet. Those are associated with a lowering in the risk for breast cancer. In a woman who's at an extremely high risk for breast cancer, perhaps she might have a genetic predisposition to breast cancer. Some women may opt to have prophylactic or preventative surgeries. That obviously can greatly lower the risk of breast cancer. I think of Angelina Jolie and some other celebrities that have been very public about their own decisions. By no means is that a necessity, but some choose that. And then there are medications that can help lower the risk for breast cancer as well. We now use a drug called tamoxifen, a drug called raloxifene, also called Avista, or a drug called anastrozole, all geared at trying to lessen the risk of breast cancer, used in women who are at a higher risk for breast cancer. We don't generally recommend those medications to be considered in women at what we consider average risk, but in women that are at a higher risk.
Laura, do you have a question?
So we have a lot of questions. Our audience is very curious. We do have one specifically about the preventative measures that you were just talking about. She had specifically mentioned the treatments you had just stated. Can you give a little more information about how she can get started with those and how to start that conversation maybe?
Sure, absolutely. That's a great question. You want to be referred to somebody who has a working understanding about the role of preventative therapies in breast cancer. And most of the time, that's where a medical oncologist like me comes into play. So I would talk to your primary care doctor or your surgeon, if you see a surgeon regularly, and have a referral made that way. We do get patients that get referred to us from our high-risk breast cancer clinic or a high-risk breast clinic. These are women who go to see the surgeons because of a higher risk, and then they get referred to me or others in my clinic to discuss the anti-estrogen therapy options. And that's a pill, again, that can be taken for 5 years, and it takes the risk of breast cancer and essentially cuts it in half. So if a woman has a 25% chance of developing breast cancer, it would cut it down to 12.5%. So that's kind of the conversation we have. And of course, no medicine is without its potential risks and side effects. So we would have a very detailed conversation weighing the pros versus the cons, sort of a value discussion as to whether it's really the right thing for her.
We had a couple of questions that came in prior to our program today, so let me ask them real quick, and as best as you can, try to answer them. Granted, these people are not patients of yours and so forth and so on.
Okay.
So the first question came from Mel, and the question is there research regarding IVF fertility treatments and breast cancer concerns or breast cancer risks? And that's a question from Mel.
Well, thanks, Mel. That's an important question and one that we do confront in the clinic. And I think it's certainly a very important question, especially now that in vitro fertilization has become very commonplace in society. And the good news is that we do have good data looking at this. I mean, we're now, 30 years into the IVF era. And there's many series that have looked at large populations of women who have had IVF and compared them to a non-IVF containing receiving population. And there's been no signals that have come from the IVF community that there's a heightened risk for breast cancer. And, the way I try to reason this is that when IVF is done, in vitro fertilization, usually there are very short but high spikes of hormones that occur as part of the treatment. And when hormones seem to increase the risk for breast cancer, it has much more to do with a longer exposure rather than short spikes. And that's probably why, in part, IVF doesn't seem to increase the risk for breast cancer. And we know that pregnancy is protective with regards to developing breast cancer. So if an IVF is successful in leading to a pregnancy, in a roundabout way, it actually may ultimately lead to some reduction in the risk for breast cancer. So I think it's safe to do that. The IVF doctors all are aware of this as well. So I think it's okay.
Another question is from Narda, and this one is a little bit longer question, but it offers a lot of good detail. When a female is told that she now has breast cancer and must do X, Y, and Z, it's very hard. It's very hard to conquer or comprehend. She is now in a predicament that makes her feel that she is all alone in this world. Why is that? Even though you may hear of other patients going through several treatments, because there are so many different types of treatments, and we're going to talk more about that as our program continues.
Sure.
And the doctor does tell you that no one patient is the same. Why can't there be classes to help walk you through this type of disease so that individuals will not feel so alone?
No, Narda, thank you for that question. I think any major health issue can become quite isolating, especially if at the time that you are diagnosed, you are not surrounded by people that have a common understanding. So I think it's very important to find an environment where you have people that have common understanding. We certainly will rise to the level to try to provide insights and education as quickly as we can. We definitely try to encourage our patients to get involved in support groups, and there are many in the area. And in our electronic era, there are plenty of really good support groups out on the internet that are very individually disease specific. So I think that's become a very great resource so that people don't feel like they're on an island. And there are a tremendous number of educational tools that are available. You have to proceed carefully, though, because on the internet, there's good information, but there's a lot of bad information. And so it's really important to have somebody guide you to the sites that are really reputable and aren't trying to lead you astray for a variety of different reasons.
Laura, you have another question from our audience?
Again, we have several, so I'm going to combine them for us. This question is about how to deal with a diagnosis, so it's twofold. Does GBMC offer any counseling to patients and families after a diagnosis? And how do patients address the benefits versus cost of cancer treatments?
Two very, very important questions. So yes, we definitely want to look after not only the physical needs of our patients, but the emotional and, if necessary, spiritual needs of our patients. So we do have counselors in place. We have a wonderful oncology support program that is staffed by a very wonderful group of individuals, including counselors, that can look to ease the experience from a psychological standpoint. We have access to a psychiatrist through the program. We have an integrative medicine specialist who's a physician who is wonderful at helping our patients with issues of mindfulness, which is trying to sort of get out in front of the disease through one's own coping mechanisms. So we really see the psychologic coping with the diagnosis as important as we do the medical coping or the medical therapy. The second question was, how do we balance benefit from cost? I kind of alluded to that earlier when we talk about even preventative therapy, that it's a value judgment, and costs can come in different forms. There's certainly the financial costs, and Lord knows medications in our country are way overpriced. That's a topic for another day. But we do our best, through our social workers especially, to really try to find ways to make therapies affordable. And there's a lot of wonderful resources out there. And actually in the breast cancer space, as we call it, there's actually a tremendous amount of resources just because there's such a developed community for caring for those that go through breast cancer. Variety of different organizations that I'm sure you've heard of. So we have to take into account financial costs, but we also have to take into account toxicities and side effects, and that's always central to the conversation, and that obviously has to be weighed against what the true benefit's going to be. And in some situations, the benefits are tremendous, and the balance clearly tips towards the therapy. In other situations, it may not be so obvious that the treatment is of benefit or of enough benefit to be, quote unquote, worth it for the patient. And those are very important conversations, too.
One more question we have from an audience member. Connie asks, my sister was diagnosed last year with her 2 NEU triple negative stage 3 breast cancer and has since had a mastectomy of the right breast, chemotherapy, and radiation. What are the odds of beating this? What do you think?
So Connie, I'm sorry that she's going through that. That's an understatement, and I hope that she does well. Let me just broaden it out to talk about triple-negative breast cancer in the first place. So triple-negative breast cancer is a particular type of breast cancer that's rather uncommon. It occurs in about 10 to 15% of the women who are diagnosed with breast cancer. And it has the potential to be very aggressive. Part of that's because it's innately aggressive. Part of that's because we don't have certain tools that we can use to combat it. We can't use anti-estrogen therapy because it's what's called hormone receptor negative, and we can't use something called HER2 targeted therapy because it's HER2 neu negative. So some of our armamentarium is limited, and that adds to why these can be difficult diseases to treat. But it's also important to point out that triple negative breast cancer is not just one disease. There are some forms of triple negative breast cancer that are extremely responsive to chemotherapy. In fact, more responsive than any other breast cancer that we treat. And there's a subtype that's not very responsive at all. And so a lot of how one is going to fare and what the prognosis is going to be is where somebody might fall within that spectrum. Sometimes we will actually give chemotherapy before surgery so we can see in real time whether it's had an impact against the cancer, whether the cancer shrinks. And that can be very useful information in triple-negative breast cancer to anticipate one's risk after surgery. I don't know, Connie, if your sister had that. The one patient that always comes to mind, she was diagnosed with triple-negative breast cancer 12 or 13 years ago. She had 29 armpit lymph nodes involved, which is a huge number. And I saw her in a clinic 6 months ago, and she is doing great. The other thing to say about triple-negative breast cancer, Connie, is that there's a timing issue here, and that is that for your sister, the next 3 years are going to be really critical, because if a triple-negative breast cancer is going to recur, that typically happens within the first 3 years, and almost certainly by the first 5 years. So once she gets past that 5-year mark, for the most part, she's home free. And so that's a really important point that I really try to drive home to my patients with triple-negative breast cancer, especially when they're farther down the road. Contrast that to the more common type of breast cancer, early-stage breast cancer, which is hormone receptor positive, where half of the recurrences are in the first 5 years, but the other half are 5 years and beyond. So it's a biologically different diseases have different time frames of recurrence.
Joining us today on our program here on To Your Health is Dr. Robert Donegan, a medical oncologist and hematologist with the Sandra and Malcolm Berman Cancer Institute at GBMC. Dr. Donegan, let me ask you a question. If anybody wants to find out more information or to schedule an appointment with you or one of your colleagues, what's the best way to do that?
So we got 2 ways. We got a phone number, which is 443-849-3051. That gets you right to our front desk, and we have a process in place to get new patients in efficiently. There's also a website, which is www.gbmc.org/medical-oncology. So www.gbmc.org/medical-oncology.
Yeah, there it is right there.
Oh,
there you go.
go.
Oh, yeah.
All right.
So let's talk about some treatment options, okay? But before we do that, there's so many treatment options that are out there, right? So which factors are you taking into account when deciding which breast cancer treatment is best for patients?
So there's so many different things that play into this, and there's not really one set answer. I mean, there are really so many different scenarios, and it's going to be different if we're dealing with somebody who has early stage breast cancer, meaning non-metastatic breast cancer, where the intention of therapy is to try to prevent it from ever recurring and improve one's cure rate. It's going to be different if somebody has advanced or metastatic breast cancer, where the goal of therapy is not so much to get rid of it, but to contain it and control it so that they can go on and live a longer life and a better quality of life. So the goals of therapy need to be very clearly defined out of the gate. And then what tools we use, what comes to bear, is really dependent upon the type of cancer. As mentioned earlier, there can certainly be a role for surgery, especially in early stage breast cancer. Radiation therapy oftentimes plays a role if a woman were to have a lumpectomy as part of her initial surgery for breast cancer. And then in the medical oncology realm, our tool bag has a whole bunch of things in it. It has anti-estrogen therapies in this situation where we have hormone receptor positive breast cancers. Chemotherapy, which is not as specific as hormonal therapy, simply interferes with rapidly dividing cells, and it takes advantages of the cancer's vulnerability that way. We have what's called targeted therapy. I mentioned one earlier, I think, called Herceptin, which can target a very specific abnormality on some cancers. And then you mentioned earlier, John, immunotherapy as well, which is starting to emerge in the breast cancer space, although still pretty early.
Can we talk, for just before we get to more about immunotherapy, can we talk about any possible emerging therapies that are in clinical trials, maybe at GBMC, that some of our audience members might be interested in or looking up?
Yeah, so we have a very developed clinical trial program here at GBMC. We're very proud of that. It's very well supported by our patients especially. One of the reasons to do a clinical trial is to try to maybe get something that's new and improved. I think a lot of patients also like the idea of clinical trials because they have what I call a therapeutic altruism. They want to not only hopefully help themselves, but help the many other women who are going to come behind them, and I think that's very much something to be commended. So we have clinical trials that look at some variations on surgery, whether less surgery might be as good as more surgery. That's very important. We have clinical trials that are looking at different uses of radiation therapy, again, trying to look at whether less radiation therapy may be just as good. And then we have a variety of different medicines that are being looked at. Similar to what I said earlier, different new endocrine therapies, targeted therapies, and as well immunotherapy too.
And real quickly, in 20 seconds or less, can you talk about the integrative medicine part of this at GBMC?
Yeah, I mean, that's something we're very much supportive of and very much excited about. I think we recognize that there is the conventional therapy that's very important to the patients, but patients are oftentimes seeking to do things beyond just the conventional therapies to help themselves. There's a tremendous need for that. And so we do have an integrative medicine specialist. I mentioned her name earlier. Her name's Dr. Kira Monte, and she's a relatively new addition to our team and has been a wonderful support to our patients. She helps with mindfulness issues. I think I talked about that earlier, sort of mind over matter sorts of ways of coping with the diagnosis itself or with symptoms that are created by the treatments, for example. She has a developed understanding about some other things such as acupuncture or massage therapy and has been a really great connection for that. And also has a developed understanding more about some of the supplements and the herbs that many of our patients are very interested in exploring. So, yeah.
So we talked about immunotherapy. There's science out there that says that it's especially promising for patients. So let's talk about immunotherapy and why is it important when it comes to breast cancer? And then the other part of that question is, what are some of the criteria that makes a breast cancer patient an ideal candidate for immunotherapy treatment?
Sure. So let me, not to rain on the parade of immunotherapy, I think it's an important tool, but I want to put it into perspective. I want to drive home that the most important therapies and the ones that have had the most impact are the surgery, radiation therapy, chemotherapy when appropriate, anti-estrogen therapies. Those are still the foundational tools that we use. The concept behind immunotherapy, and it's getting a lot of attention lately, is that there's long been an understanding that one of the reasons cancer cells are able to grow in the body is that they are sort of invisible to our own immune system. Our immune system is really designed at trying to attack cells that shouldn't be there. I mean, obviously we think about it with bacteria and viruses, but also cancer cells. And cancer cells, in some ways, they're pretty smart suckers, and they camouflage themselves. So the idea behind immunotherapy is to try to see if we can remove that camouflage and now make that cell more visible to our own immune system and to fight off the cancer. And we're probably about 8 or 10 years into the immunotherapy era. Most of the immunotherapy that's been successful has not been in the breast cancer setting, but in other diseases, particularly diseases that are associated with exposures. So lung cancer and tobacco smoke, bladder cancer, melanoma because of the sun exposure. These types of cancers tend to be more visible or more affected by immunotherapy because these cancers have a lot of what are called mutations in them, and that's what seems to make the cancers more visible. Breast cancer doesn't have as many of these mutations, and that's probably why so far, at least with our understanding of immunotherapy, it hasn't been as effective. That said, earlier this year, the FDA approved the first immunotherapy for the treatment of breast cancer based upon an important study that specifically looked at metastatic triple-negative breast cancer. And it showed that when a standard chemotherapy was combined with an immunotherapy, that there was a greater degree of response and duration of response. It wasn't a home run hit, but it was a double, and that's a start. So I think that's now opened up the doors to a lot more investigation of immunotherapy. There was a study just presented in Europe last month that actually looked at placing an immunotherapy into the treatment of early stage triple-negative breast cancer before surgery, and it seems to show some hopeful signs that it may actually make a difference in earlier stage disease. So I think this is kind of the beginning of the immunotherapy era in breast cancer. I think we have to get a lot smarter about how to make it work better or how to better select patients who are really destined to benefit from it. So to be continued. This train has left the station. There's going to be a lot more coming down the pike. We'll have to see.
We only got a few more minutes left before the end of our program. So real quick, give me like 2 or 3 if there's any side effects to immunotherapy. Is there?
So there can be. I mean, general immunotherapy for most patients is better tolerated than chemotherapy in general, but there are some patients that do develop side effects from immunotherapy. Sometimes it's a real turning the switch to the immune system, and so you can imagine all this inflammation can occur. So people can get inflammation of the lungs, inflammation of the colon, inflammation of the endocrine glands, and so on. So it's not without its risk. I will tell you that now that we're all more accustomed to using it in the clinic, I think we've gotten a lot better at anticipating side effects and managing those side effects too.
All right. So let's recap real quick. Immunotherapy by itself, okay, still being looked at, combined with chemotherapy, maybe a better effective treatment, let's say, right?
Correct.
Can we say that? Is that safe to say?
Yeah, I think so.
Some side effects, but they can be managed, right?
Sure.
So that's good. Okay. So real quick, we got about 2 more minutes left. Here's the big question. Can you ever be cured of breast cancer?
So the short answer is yes, although let me expand upon that. So we know that with breast cancer, if 100 women walk in the door with a new diagnosis of breast cancer and we go downstream 20 years, 80 of them are going to be cancer-free. So most of them are probably cured of their disease. But I guess the question is, how do you define cure? I've had patients that, I actually learn a lot from my patients about this question, because I have some patients who have a very low risk of their cancer recurring, but it's not a 0 risk. And they tell me that as long as they live with a risk of the cancer recurring, they don't consider themselves cured. So almost, the fear of recurrence sort of means that they can't be cured. And I've had other patients who say, Doc, I'm doing great, my chances look pretty good, I'm convinced I'm cured, and I'm going to go about living my life as so. And so for that patient, they're cured, and I'm all for it. So I think it really almost just depends upon what the patient says, but I do believe that patients are cured of breast cancer.
We're down to our last minute. So this is the part of the program where we go with true, false. I ask a couple questions of our guests, and they give us a true, false answer. So here we go. You ready?
All right, sure.
You sure?
Yeah, I'm ready.
All right, here we go.
Sound to me.
Breast cancer can only affect women.
That's not true. 1% of breast cancer occurs in the United States every year. About 2,000 to 3,000 cases occur in men, I should say, in the United States. So it's mostly a disease of women, but 1% occurs in men.
Right. Wearing a bra can cause breast cancer.
No. Most women who get breast cancer have worn a bra, but I would not say that bras cause breast cancer.
If you watch your weight, eat healthy, limit alcohol, and exercise regularly, a woman will not end up with breast cancer. True or false?
Well, she will certainly lower her risk for breast cancer. I wouldn't say that she will not end up with breast cancer, because even despite the best of efforts, sometimes it happens. But certainly the risk will be lowered. And importantly, the biggest killer of breast cancer survivors isn't breast cancer, it's heart disease. 10 times more women die of heart disease in the United States every year than die of breast cancer. So all of these efforts to live a more healthy lifestyle to lessen one's breast cancer recurrence risk, greatly benefits a woman from the cardiovascular standpoint. So that's a real important point to drive home.
Unfortunately, that's all we have for
right.
today. But I want to thank you for joining us. The conversation continues on Greater Living Live with Mary Beth Marsden. So if you have any questions, save it, and we'll see if the guests for the next show can answer them for you. I want to thank you all for coming here today. And again, like I said before the show started, I hope that you all learned something new today. And of course, how could you not with this plethora of information that was provided by our excellent guest here today. Next time on To Your Health, we're going to be talking about what's new when it comes to treating eyes and eye disease associated with those that are diagnosed or with diabetes or pre-diabetes. So please look for more information on the GBMC Facebook page. And if you have any questions, for Dr. Donegan that we couldn't answer to today, please submit them in the comment section of the GBMC Facebook page or private message GBMC Facebook page, and we'll see if we can get that information to you. Dr. Donegan, thank you very much for joining us.
Okay.
Until next time, cheers and to your health.